It's 7 a.m. on April 22nd, 2020. Good morning, ladies and gentlemen. My name is Jens Chapman, the man behind the mask speaker. On behalf of my faculty colleagues at the Swedish Neuroscience Institute and broadcasting from the Seattle Science Foundation, I wish you a very good morning. Today is one of our STED talks, and I have no disclosures relevant to these things. Reflecting upon this memorable spring of 2020, I hope all of you are socially distancing and enjoying the empty parks where permissible. I'm sure by now you've become experts at decoding even smallest facial expressions on Zoom meetings. And Zooming patients is now a good thing, where you're basically trying to emulate a physical exam on a patient by a screen. We obviously have really had a great opportunity to do a lot of good content meetings, and just last night we had a great meeting with multiple universities around the country. Here you see Dr. Izzy Lieberman from the Texas Back Institute, and we had a focus talk on laminoplasty, a cervical spine procedure. From a healthcare professional standpoint, I do think that things have changed a little bit. This is a cartoon from the NHS, and where all of us were feeling very weaponless and kind of exposed, and maybe still are somewhat. The tide is changing, and I think more and more people are getting the protective equipment that we need, and we don't have to recycle our masks too much anymore. A big thank you to the wonderful core team of SSF with Rod, Lee, Linda, and Alexis, who are doing an absolutely wonderful job connecting the world through quality education. This program is a so-called STED talk. Why STED? Again, spine care has multiple different, and there are way more than that, problem areas, and there are many unresolved questions in this. And so we've basically, in paraphrasing a certain other talk series, identified the spine technology education, discovery, discussion, and debate format. Seeing the spinal column as an organ system, which it should be technically, reflecting on advances in technology, trying to have a quality, multifocal approach towards education, and having the D separated into three components. Discovery, which again is composed of recognition, research, and improvement, and discussion, comparing, questioning, and exploring things, and debate, which is a far more vigorous kind of diatribe in terms of substantiating, validating, and refining our approaches. I'm very excited to present today's topics to you. It pertains to the cervical spine and disorders of the cervical spine. And we're looking at, and you'll see that in 3 case discussions and in 2 scientific presentations of 2 of our wonderful fellows, aspects of function, dysfunction, reconstruction, and patient-reported outcomes around the cervical spine, a relatively small area of our spinal column right up here, from the occiput to the first thoracic vertebra. And the talks as such will really revolve around some aspects of this. So thank you very much for your attention. Thank you for your philanthropy, helping us support the 100 Meals a Day effort together with Baba for our healthcare workers. Our first speaker will be Dr. Bilal Ketene, and he's going to present a case that he was involved with. And we'll probably have a brief discussion about it also. So Bilal, I have not wiped this down yet, so I'm going to wipe this down quickly. Okay, let's wipe down. Sorry. Thank you, Bilal.
Thank you. Good morning. My name is Dr. Bilal Kutina, one of the spine fellows at Swedish Neuroscience Institute. A 49-year-old male slipped down into recessed tub, head injury and neck pain, no loss of consciousness, and he is generally healthy. On exam, he is neuro intact, and this is his CT. On sagittal CT cuts, we see that we have C2 fracture, C1 fracture, fusion of C2, C3 facets, and also arthropathy of C1, C2 complex. Axial cuts, which showed the fracture in C1 anterior arc, also in C2. Also coronal cuts, which show arthropathy of the C1, C2 complex and fusion of the facets C2, C3. On MRI, we have intact transverse ligament, neck CT angiogram normal, head CT non-displaced fracture of the left anterior maxillary sinus. Regarding classification of atlas fracture, in type 1 we have anterior arc, in type 2 posterior arc, in type 3 we have the Jefferson type, which is combined anterior and posterior arc. Now type 3 we have A and B based on transverse ligament injury. Type 4 we have lateral mass fracture, and type 5 transverse process fracture. And in 4 and 5 we have to rule out vertebral artery injury. Dickman transverse ligament injury classification, which separate the transverse ligament injury into interligamentous injury and to osseous injury. Osseous avulsion is better than interligamentous injury. Regarding the classification of C2 fracture, type 1 we have the tip, type 2 it is the waist, type 3 through the vertebral body goes through the facet, so we have type 2. Regarding the AO classification system, it is region 3, which is the C2-CTU3 joint, and it is type A. Now, in the AO classification, there are a lot of modifiers, such as the age, ankylosing spondylitis, and the type 2 dense fracture is considered as a modifier because of the high non-union rate, which push more towards surgery. Treatment options regarding this case.
So I'm gonna come up front next.
Yeah.
The microphone's not working.
Yeah. Stay there. Yeah.
Bilal, I'll ask you first, since I'm on microphone, because I'll have my mask on. So this is obviously something that will probably not heal well just with a brace. But fusing the upper cervical spine will be a big problem because the patient will lose half of their rotation. So you're a surgeon, you're a brilliant young surgeon, you're gonna be working at the Hadassah and Israel, you're gonna be a mainstay. Knowing what you know, what would you choose? Would you have a halo for 3 months with a roughly about 30% chance of not healing after 3 months and still needing surgery? Would you have a fusion surgery or trying a screw fixation where you know that it's probably not going to be very strong because the C1 arch is broken? What would you do?
What I would do surgery, posterior spine fusion, because non-operative treatment and halo have high non-union rate. And the anterior odontoid screw also will fail in this arthropathy and fusion of C2, C3 complex.
Let's ask a senior spine surgeon, Dr. Oskuyan, what would you do to yourself? I mean, this is a C1 arch fracture with a shear. It's an AO complex C1, C2 injury, a type 2 odontoid fracture. What would you do, a halo and hope for the best, not operate for 3 months?
So do we have the axial views?
Yeah,
I think
of course.
the fact that there's a C1 fracture, I think actually the healing rate is much lower.
This is the same fracture.
I think, for just bread and butter odontoid fractures, I think it's 35%. But for this, I would say it's probably greater than 50%. And I think for me, I mean, anything short of surgery, it's going to fail. So, I mean, you can halo, you can do collar, you can futz around with trying not to, but this has to be operated. It's posteriorly displaced. It's extremely unstable. Is there an MRI?
Yeah. In MRI, we have intact transverse ligament and no compression.
Yeah, I mean,
This is the MRI.
this is going to fail if you don't operate.
All right, is there anybody who'd want to go for surgical treatment? By the way, we have only 10 people here in the room, or we're under the maximum legally permissible room numbers, occupant number. Anybody who'd want to go for halo and tell us why? This is not a pressure question. No? All right, so I think we have a consensus actually that everybody's in favor of surgery. Tell us what was done and how the patient did.
Yeah. First of all, a few words about combined fracture of atlas and axis. They are rare. They are more frequently associated with neurologic impairment and increased morbidity and mortality. There is no strong consensus on how to treat such fractures. Each injury needs to be evaluated individually. Now, regarding this type of fracture, type 2 odontoid and C1 anterior arc, it is very rare combination. We have case reports about 7 degenerative changes in C1, C2 joint, which fix the odontoid to the anterior arc of the atlas, and usually the mechanism is spinal hyperextension. This is what we did: posterior spine fusion, C1 to C3, AP lateral X-ray, and flexion and extension, and he's doing great.
Excellent, thank you. So when you inform a patient of doing a fusion of C1, C2, what do you tell them in terms of loss of motion, Bilal?
I will tell him that we will lose about 50% of the rotation.
Showing it on yourself, how much is that? Just show the audience how much
This is
they'll
the
lose.
normal. Yeah, 50% will be like this.
What does that mean in everyday life? What activities do you think are mainly adversely affected?
If he do sports, driving, it may affect him.
Okay, so driving?
Yeah.
What activities specifically in driving?
When he turn, when he try to look around.
Yeah, so we've actually looked at that, and we'll have a great talk by Dr. Heyman later what that means. But basically, turning is one of the big things, backing up a car. When you have a Y merger on a highway, those are the things that you want to tell patients, and there are obviously accommodations for that nowadays. But that's probably one of the leading things that I've heard patients complain about, and that's not been really investigated very well. No complications with this patient?
At all, no. And he's doing great.
Dr. Askuyan, can I ask you, so this kind of a construct uses these C1 screws. What about the C2 nerve root, which runs between the C1 and the C2 screws? Do you take that or not? This is a very functional, 45-year-old, very active man.
Absolutely. I take it every time. Because for me, it really adds very little extra time. And you're going to have to burr out the facet joint. And I think it's, in my experience, you know, they complain for about 6 months, and then it kind of goes away. But I always joke, and this is probably, you know, C2 nerve root is a sensory nerve. And if you break your neck, you get one of the downsides is you lose rotation and you have permanent numbness. So, but I know there's two different schools of thought. What did you guys do?
We preserved it, and it worked well. So, but your points are taken from an axis into the joints. Can you put the marker onto the C1, C2 joints, please, Bilal? Preserving the nerve is obviously nice. No, C1, C2 joint. Yeah,
C1,
go
C2.
below the screw at C1. Show us the C1, C2 joint. Yeah, it runs right along the waist. To get into that joint is much nicer to take the nerve off, but it's more blood loss and everything like that. So we preserve it, but your point is well taken. And Bilal, what numbness do you get when you take the C2 nerve root?
It's on the posterior neck in the occipital region.
Do you mind showing the audience where that is, roughly? Yeah.
And behind the ear.
Yeah. And it's not permanent. So, Rod, you said that patients gain sensation back. How can they do that?
So they don't get sensation back. I think it's plasticity and cortical reorganization, and it's been shown in stroke. And so what happens is if you have a large area, in fact, even in our surgical patients, you'll find patients will complain of numbness, let's say over their incision. Because that nerve's been cut, all those cell bodies in your brain actually stop functioning because those axons have been cut, and those cell bodies actually get recruited to partake in different neural activities. So,
very interesting. Okay, thank you, Bilal. Next, we have Dr. Ben Schell, and he's going to demonstrate a different take on a cervical spine dysfunction.
I don't mean to derail the conversation, but just as for another discussion point, when do you guys stop at 2 versus go to 3 versus go to 4? Because we've done a fair number of C1, 2 where we stop there, and then is it just bone quality or?
Great question. So this patient had an underlying, and that added to his whole thing, arthritis process. He was on a chronic medication for that. And so he had poor bone stock. He had already had a congenital fusion of C2-3.
Got it.
So basically just opportunistically included C3.
Sure.
Otherwise, I would limit the fusion to C2, since we usually have very strong fixation there, just as in this case.
Gotcha. Perfect. So like Dr. Jim said, I'm Ben Schell. I'm one of the other spine fellows here at Swedish, trained at UT Southwestern and headed to Charleston next year to practice. So this is another take on the cervical spine, otherwise healthy, 49-year-old active guy. He's a police officer, still working in the field, but he's had this kind of neck and arm pain for over 20 years. Off and on, seems to be activity related, and then, through this process, failed conservative care. And then, it bothers him considerably amount, not too bad, NDI of 19. And there's his exam there. It's not showing up on my laptop. You can see a little bit there. It's kind of an isolated radiculopathic pattern. And then here are his x-rays showing a focus of pathology kind of in the lower C-spine. No restriction on his range of motion, but it's a lot of axial neck pain. And then the radiculopathic pattern. And then here's his MRI. I apologize, the axial is a little dark, but you can kind of see the foraminal stenosis there on the second image from the left, showing the right foraminal stenosis. And then on the axial as well, you can see it right there, that 5-6 level. And then the CT myelogram is another test we often get here at Swedish to really tease out where the pathologies are coming from. He had some nerve injections that were kind of inconclusive. Physical therapy wasn't really helping him. He'd failed, NSAIDs for so long that we really wanted to find where this pathology was coming from. So I got the CT myelogram because it traces out those nerve roots and we can really see what's going on here. And you can kind of see the multi-level degeneration right there between 4-5 and 5-6. So I'm sorry, 5-6 and 6-7. And so kind of the options here were to, from continuing conservative care, he's still able to work, but not great. He's not happy with his job performance. They're telling him at the police they're slowly decreasing his work activity down at the police department. And he's getting more and more frustrated. He's right-hand dominant, so it's affecting more of his right hand. So there's talk about going from posterior, doing the foraminotomy posteriorly, and then the options that we discussed with him: 2-level anterior cervical discectomy infusion. But again, you lose that range of motion, especially with 2 levels. So you're kind of going back and forth with him about that. The arthroplasty discussion was also had, but with a 2-level arthroplasty, the FDA hasn't fully approved all of those implants, so it's not as commonplace as a 1-level, but we felt he had 2-level disease, and then, going only posteriorly and doing a laminectomy was kind of the last discussion point with him, and felt that wouldn't really address this problem that was mainly on the, right foramen. So, I don't know, open to questions before I show you what we did.
Rod, so this is a police officer. He works in one of our police departments in a frontline function. He's a SWAT officer. He's a very strong guy. You can see his neck is bulky, and he's worked out. He's a former football player. He has this typical cervical 5-6, 6-7 disc degeneration, which now has kind of mushroomed out into the foramen. And maybe, Ben, you can go back 1 level and put your cursor onto the sagittal, the second from right, this time just to show how there's an obstruction of the foramen. Second from right, so go 1 over.
Yeah, so
and
there's
just put your cursor right onto when you put the highlighter onto the foramen, and show how there's a bump sitting in there. So Rod, we had a great journal club, and by the way, we have a journal club on Friday again, 1 lower, go 1 lower, and show these black bumps in there,
Black
and
bump, and
where
then
the nerve
you can see
is.
it's kind of open down here.
Yeah.
And then there's the black bump impeding on the foramen.
So we talked about in our journal club hosted by Rush University that they showed a study from Sweden where there was not a big difference of 2-level fusions and foraminotomies. And Dr. Ahn from Rush last night in our session said, well, foraminotomies are fine if they're on one side. This guy has kind of bilateral symptoms. What do you think about foraminotomy in a setting like this? Isn't this a simpler procedure where you just cut open the back and open up the nerve exit hole, despite the fact that a disc osteophyte complex is in the front?
Oh, you do? Okay. So I think, go back 1 more slide. I mean, this is a perfect case for an artificial disc replacement.
This guy.
Because of his lifestyle, he's active. He has only radiculopathy, right? Not much neck pain. If you go posterior, you're going to guarantee he's going to have neck pain, and he's going to be back in your office. The foraminotomy, in my experience in these cases, it's a good operation, but if they're active and it's a firefighter, it's almost like operating on an NFL player. I go anterior all day long.
Anybody opposed to going anteriorly? Now, he's a police officer, he's a SWAT officer, and he has significant physical tasks to fulfill and fitness tests. Would you let him go back to unrestricted duty with a 2-level disc replacement?
Yes. Yeah, without question.
Wow, okay. All right.
How long would you make him wait?
3 months.
3 months?
3 months. All right. Let's see what you did.
So here are intraop fluorofilms, 2-level disc arthroplasty. Everything went well. You can kind of see comparing the laterals there to the prior ones. We had to take down a lot of that osteophyte, considerable osteophyte, especially on the right side, where the body was trying to fuse and slow down those vertebral levels. So we took all that down. I got the arthroplasties well positioned. He did great. Was only in the hospital overnight. And then there are his FlexX films from his most recent follow-up at clinic. He's about 10 weeks out. And so he's gone back to some light duty at work. He's not officially back in the field as a SWAT officer, but he's able to do some, well, maybe not now with the pandemic, but he's able to do some type of admin roles as well, or he was. But he's doing more, being active. Neck pain's resolved, right arm pain's resolved. He's very happy with the outcome. So,
what's his range of motion of his neck like?
We haven't, I guess, physically seen him in clinic. It's only been over the phone, but he doesn't feel restricted.
Yeah, so that's one of the main things, that the range of motion for cervical disc replacements is supposed to be unrestricted. And the only drawback is that they don't have a cushioning effect, but the actual arc of motion is pretty much normal.
Yeah.
So long-term impairment, provided that he continues to recover well and without delay, what do you tell him? What's his disability with a disc replacement?
I don't think there should be, much disability at all with his disc replacement. He, once we get out of that 3-month window where we're getting, adequate x-rays and he's pain-free and his arm pain's resolved, I think he should be able to, like Dr. Schoon said, go back to, what he was doing beforehand, because as long as we're getting adequate apposition here between the implates and bony ingrowth on those implates and everything's stable, then I don't see why he couldn't do what he wants to do.
And if a patient asks you, how long do they last, what's your answer?
So I think a lot, like the research that we looked at, from Dr. Ziegler's talk in the lumbar ADR, and then kind of the research we're getting, from the total knee literature and the total hip literature, looking at, how long these high molecular weight polyethylenes last. We're getting studies out in the 15 and 20 year mark. I have not seen one post-op that long yet, because we don't follow them out that long, but I don't know. I would say at least 15 to 20 years, just because of what we know.
Yeah, so 15 years is the pretty much max published right now, and the reoperation rate of disc replacements so far is much lower than that of fusions. So that's a big deal. So hopefully this fusion disease, where other levels get worn out prematurely, is much reduced.
Yep.
Aside from maintaining function.
So just looking at, why did you choose to use the Mobi-C device over, why did you choose the Mobi-C over ProDisc? Ben, I'm asking Ben.
Oh, you're asking me. Okay, so we originally do like the ProDisc for a lot of arthroplasties here, but his insurance wouldn't approve it.
Okay, this is where I would say this is crazy, just because it's constrained versus unconstrained, and it didn't go in FDA, IND trial, IDE trial, because, we know if you put in a ProDisc for 2 levels, do you know the difference between the 2 discs, Ben?
Yeah, so the Mobi-C has a lot. It really is Mobi. it really, that poly can slide around a lot more, as opposed to the ProDisc that is just locked in.
Yeah. So this is one case, Jens, I would actually say, tell the patient, look, we have these 2 discs. One is more constrained, one is less constrained. And I think it's perfectly legitimate. I think it's crazy that the insurance companies wouldn't approve a device that's more rigid versus one that's more mobile.
I agree. This is somewhat of an administrative overreach, but he was in pretty significant misery and his professional life was on hold. So now he's back at work and we have every hope to bring him back to full work. And again, there's no greater failure rate published with this device so far, but I instinctively agree with you. I would have preferred a more restrained disc replacement.
Yep.
Great. Well, thank you, Ben.
Last slide, a little shameless self-promotion, my ongoing research project. If anybody has any time, check out the SSF website for the MROCs.
What are you doing there? Just tell us. What are you doing?
So I'm trying to classify multiple rod constructs. We use a lot of them here at Swedish, and they're kind of becoming more commonplace throughout the United States. So I have a short talk about looking at different cases that we've done here at Swedish and trying to apply my proposed classification system. We're compiling all the data, try to make it reliable, and see if we can improve on it. So there's a survey here that's on the PowerPoint that hopefully those links will work, and then there's a talk on SSF as well. So any and all help would be appreciated. Thanks.
Thank you. So that'll be a great opportunity for everybody to get involved and work together and help this very important subject of trying to get some more sense into multi-rod constructs organized. Okay, so our last speaker for cases is Dr. Ryan Goodmanson, and he put together a talk on a patient who had a fusion and had a problem from that. Ryan.
Thank you. All right. So this is a 55-year-old male. He was a firefighter. Previously, he had a surgery done, and really was an uneventful surgery, but we'll talk about that, and it was done in 2019. Really fairly healthy individual of note, though he was an everyday smoker and drank every day and also used marijuana, which probably comes into play a little bit with this. But just to go back in time, in August, he had this fusion done for his degenerative disease. And you can see on the CT scan there on the left, he does have kyphotic type disease, probably expanding from C4 down to C7 with some osteophytic formation as well. And if we go to the MRI, I don't know what just happened there. Oh. I think I crashed it with my video. I'm sorry. Let's try this again. And if we look at the MRI, this reflects his disease as well. And so because of the symptoms that he was having with radiculopathy, a little bit of weakness, but also pain, he was referred for ACDF of his C5 to C7. This was done very uneventfully. Again, he did very well afterwards. We have some imaging of close to the time after surgery. You can see that the fusion was done. This image was taken probably about 4 months after his initial surgery was done. And you can see maybe a little bit of extra kyphosis there at the C4-5 level, but debatable, and the patient was doing very well at the time. So he presented then to our facility with complaints of increased neck pain, unable to lift his head and look horizontally, with pain, radiculopathy, and some weakness. And if we scroll through this video, we can see that he has progressed his kyphosis above this fusion quite significantly. The construct as well at C5 looks to have failed around the screws with a fracture, and it's causing significant kyphosis in this area. So this was his exam when he came and saw us. He was a little bit hyperreflexic in his lower extremities. He did have some weakness in his finger abductors as well as his elbow extensors on the right. but really no long track signs to speak of. This is just a sagittal cut of his MRI from when he came to visit us. You can see that, again, the kyphosis has progressed. This is even him laying flat, and you can tell that there's quite a bit of kyphosis. So the question for him is, what do we do? We can go on, or okay. So the plan for him was to do a two-stage procedure. The first stage was to remove that hardware and do a decompression of the failed hardware, as well as a corpectomy of C5 to restore his physiologic alignment. And then we did plan on doing a posterior stage as well, from C2 to T2 or T1, just depending, later on in the week. And so he underwent this procedure, and the procedure went very well. His alignment was very well restored. He was decompressed and did extremely well after surgery from this. And so the plan was then to take him a couple days later for the posterior aspect of this fusion. However, the patient declined this. He was feeling extremely well, and so he said, no thanks. So our questions are, do we insist on posterior? Do we see how he does? If ultimately is probably his decision, but we are his guidance in this, I think. And so where do we go from here?
Can you go back one slide?
Yes, sir.
Maybe one more. Yeah, so this is obviously a problem. We had a clear plan to do a front and back surgery because he has this natural inclination to want to fall forward. So he has arthritis, for instance, the C2-3 joints above, if you go the other way. So there was no question in my mind that we wanted to do that and needed to do that. We obviously told him that he'd lose about half of the overall motion of his neck by going to cervical 2 level. And this is a man who is a firefighter, and he basically said absolutely not, and then bolted. He felt much better after his anterior neck surgery had been revised, and he declined that. So my worry is that he'll obviously fall apart. We were very careful to use biologic constructs in the front and had bicortical screws. But Rod, what are his chances of healing in the front with this without falling apart?
I mean, I would say that given the fact that he didn't fuse before and the fact that he still has, do we have plain x-rays? I mean, this is a great operation that was done, but I think he's still, you can kind of see the C2-3 disc, C3-4 and C2-3 both. He still has a little bit of kyphosis. I'd be worried. You know, I'd say probably, I'll just guess, I think probably 50% chance of not healing.
Add on top of that that he's an everyday smoker and marijuana use and everything too. So
he has a real problem with probably not healing, but his worry was when we disclosed him that he'd lose half of the motion in his neck, that he would never be able to return to work. So his hope was that he would basically return to work, but our worries, which we very clearly enunciated, were very plainly stated that he'd be at a very high risk of a non-union. All right, thank you. So now you're going to run this through your own laptop? So we have Dr. Sven Frieler here. He's from Germany. And we can just slide this out here, Sven, and you can park your laptop here. Now, when we do neck surgery, there are obviously complication potentials, and the next two talks feature basically outcomes of spine surgery from two different angles. Number one, you saw anterior neck surgery being performed in several of these cases, and there's a risk of fluid collection, as you'll see. So Dr. Sven Frieler and colleagues did a very nice project in our lab on simulating what happens when fluid happens. The second talk about research will be from Dr. Eric Heyman, and he'll talk about what the impact of a fused neck is on a patient in comparison to not fusing it. So Sven?
Thank you very much for the warm introduction, Dr. Chapman. My name is Sven Frieler. I'm one of the research fellows here at SSF, and as you can see in the moment, we are 7 fellows. In case you haven't noticed it yet, I'm actually from Germany. I'm a resident at the Bergmannsheil University Hospital in Bochum, and I'm happy to present today at our STEP Talks. So today we are talking about postoperative airway compromise following anterior neck surgery. We will present a cadaver model to help understand critical mass effect in this kind of surgeries. Disclosure, we don't have any conflict of interest concerning the materials or methods used in our study. The anterior approach to the cervical spine is a common approach to many spine pathologies and, for example, used in ACDF surgery like shown in this X-ray. First, the incidence of complication associated with these procedures is relatively low. Dysphagia and dysphonia are most frequently encountered. The retropharyngeal space clinical relevance is apparent in anterior cervical spine surgery with respect to postoperative hematoma, which can cause life-threatening airway obstructions. This cadaver study aims to establish guidance towards better understanding of the tolerance of the RPS to accommodate fluid accumulation. I want to start with a demonstration of one of our cases. You see the CT of a 64-year-old female, a patient who underwent ACDF surgery at our hospital. The operation was performed without any complications, but shortly after extubation, the patient complained about dysphagia and collar tightness as well as dysphonia, and was admitted to our ICU for close monitoring. There we notice a progression of the symptoms and beginning dyspnea. At this time, the vital signs of the patient were still stable, so we were able to carry out this image, what you can see on the slide. You can see the hematoma marked with the yellow dashed lines and the significant trachea deviation marked by the yellow arrow. Of course, the patient underwent urgent revision surgery after our image. She's now doing very well, had no further complication after this revision. Here's a second example for a patient with hematoma following anterior neck surgery. We performed a CT contrast. You can clearly see the deviation of the trachea, and again, we highlighted the hematoma with a yellow marked, with the yellow dashed lines. So coming back to our study, we used 5 fresh frozen cadavers, and this picture shows our study setup. The dissection was done in the supine position. We used an anterior lateral approach for the placement of the digital manometer and a 20 French Foley catheter in the RPS. Of course, the tip of the catheter was removed beforehand so that only the balloon was inside the RPS. After this, we performed a regular wound closure. Furthermore, how you can see in this picture, we installed a suction tube in the esophagus flushed with a contrast suspension to measure the distance between the esophagus and the C5 supine process, which was our reference point. At this, we repeated the measurements with the suction placed in the trachea. Okay, our aim was to quantify the required volume to deviate the esophagus and trachea over 1 centimeter from its baseline position. Further, we recorded the volume required to cause a visible change affecting the normal neck contours. Our findings showing that a mean volume of 12.5 millimeter with 1.5 millimeter of mercury caused a deviation over 1 centimeter in the esophagus, while 20 milliliter with a pressure of 2.39 millimeter over mercury will lead to a deviation over 1 centimeter in the trachea. Moreover, we observed a visible change of the neck contour at a mean volume of 39 millimeter. Coming to our conclusions, first we notice a relatively small volume of fluid in the RPS caused radiographically deviation of the esophagus and trachea. Second, the esophagus is a second structure in the retropharyngeal space to be most readily influenced by mass effect. And third, clinical identifiable changes of the normal neck contour required twice the volume to cause 1 centimeter tracheal deviation. In our opinion, this may be a very important point. Following our findings, it seems that the clinical identifiable changes in the neck contour are not suitable as early warning sign. We recommend close observation in patients with progressive dysphagia and early intervention and workup when a postoperative hematoma is postoperative hematoma is suspected, even in the absence of visible neck change, edema, or palpable hematoma. So this picture, you should not wait until you have a patient with such a significant visible sign. It may be too late. And of course, we would like to emphasize again that all of our results come from a cadaver model. Like all studies, we have some limitations. First, the Foley balloon was defined spherical shape. This may not represent retropharyngeal hematoma in vivo, which can span several levels and present more fusiform in shape. However, the clinic experience shows us that blood will congeal and stay pretty focal at the RPS and not deviate, for example, in the mediastinum, like it's shown in this picture. Moreover, we believe that the overall mass effect in our model is comparable to the normal vivo situation. One other important point, of course, which we must consider is that our sample size was still small, and there are markedly differences in the individual neck size. Our presented study was accepted for publication in the Global Spine Journal and is in the moment in print. And furthermore, based on our cadaver findings of our group, we identified several pre- and intraoperative risk factors for postoperative acute airway obstruction and developed the postoperative airway distress score, also called PET score or just PETs. So stay tuned, we will follow up with you.
Thank you.
Thank you very much.
Well done, Sven. Great research. Can you go back to that retropharyngeal slide? So first of all, do drains help prevent this from happening? Maybe, yeah, go one forward maybe. Do drains help prevent a hematoma in the retropharyngeal space after anterior neck surgery?
That's an interesting and great question, of course. There's an ongoing discussion, so some surgeons recommend still drains, but there's a lack of data in the literature. So we have one very big study from O'Neill who looked for about 2,300 ACSS, and he could not find any prevention if you use a drain in this situation.
What can you tell clinicians is kind of the usual sequence of deficits when they do develop a problematic retropharyngeal hematoma? What kind of can clinicians look for based upon your initial research?
So for us, most important symptoms would be the dysphagia and the collar tightness after surgery, followed by dysphonia. And if they develop some kind of dyspnea, you should be very fast and reach to the operation theater.
Okay, so that's good. Any other comments? Rod, as an experienced surgeon, has done this thousands of times?
I mean, I think this is a great study because it doesn't happen that often, but when you have an upper airway compromise, it's devastating. So I'm looking forward to seeing the paper published. And I really don't think there's any good models out there. And what we find is, when we go back in, usually, like Dr. Chapman said, almost all these patients, there's it's like a clot that you take out. And so it's an organized clot, so a drain is really not going to do that much. But it happens usually the first day or two after a large or an uncomplicated anterior fusion. And I do think, and you pointed this out, there's certain patients that are more susceptible to having this.
Thank you very much.
Great. Good job, Sven.
Thanks.
So we showed a couple of clinical cases, one with a patient with a C1, C2 fusion, which deprives the patient of half of their rotation. We showed a patient with a multi-level fusion whose neck is tipping forwards. And then we showed a patient with a 2-level disc replacement. Can you plug that in, please? With a significant restoration of motion, hopefully. but the impact of neck surgery on the function of patients is still not fully understood. And one point that was made earlier was that we have some disability indices to try to identify that. And I may not be able to find your talk right now, so you may have to help me. Do you know where this is stored? So the question is, how does a patient actually feel after neck surgery? What should we try to tell patients so that you can mentally prepare for this? Do we have the talk downloaded? So here we have Dr. Eric Heyman to present the next research project that he worked on.
Hi, like I said before, my name's Eric Heyman. I'm a fellow here at Swedish, coming from the University of Maryland where I did my neurosurgery training, and I'll be in USF next year, joining the staff down there. The subject of my day, as Dr. Chapman alluded to, is neck stiffness. Briefly, I'm going to hope to convince you that neck movement is important for everyday life and functioning, and propose that taking away neck movement can compromise these activities. Next, talk about why current measurements of disability in neck, which exist, are probably inadequate for doing this. Talk about some work done last year by Dr. Hart and one of the fellows here, Andrew Jack, who developed a index, a metric tool, the Cervical Stiffness Disability Index, to provide a better tool to evaluate patient function as a consequence of losing neck mobility. And then talk about the work we've done this year to validate it, as well as its relationship to other neck disability indices. The neck is a highly mobile segment of the cervical spine, somewhere between 180 or 160 degrees of axial rotation, and then about 120, 130 degrees of flexion extension, more or less, depending on age, health, and flexibility of the individual. The reason why the neck is so flexible should be pretty obvious. It's important for directing our gaze. When you drive into work, you'll use your neck to turn around and look at cars on the road. When you're operating the OR later today, you're going to be looking down for long periods of time. When you go to the grocery store, you're going to be looking up. Your neck will be moving and be an integral part of all of these functions. Neck movement is also important in non-obvious functions. Swallowing, for instance. Everyone take a sip of your coffee. Pay attention to how it goes down. You'll notice that your neck is subtly moving during that procedure. These are not incidental movements. These are important. If you take these movements away in healthy individuals by putting them in a halo brace, so these are healthy, prospectively collected volunteers going in a simulated halo, they lose swallowing function. They will actually have not only subjective dysphagia, but actual radiographically demonstrable difficulty swallowing. Similarly, singing. We all know when Taylor Swift hits that high note, she cocks her head back. That's not a dramatic thing. When you're singing, tilting your head back actually has been objectively shown to affect tone and timbre. Neck movement is crucial for these activities and countless other ones, which we don't necessarily notice are traditionally associated with neck disability. The reason why this matters is neck surgeons, we take away neck movement. Every day we talk to patients and propose limiting the mobility of their neck through surgical fusion. You can actually watch patients kind of walk through the syllogism on their own. Neck movement is important for a lot of stuff I do. Cervical fusion results in loss of neck movement. Doc, when you fuse my neck, what's going to happen to my ability to do X, Y, or Z? And unfortunately, surgeons, we don't have a great answer for that. We can say you'll lose 50% of your neck rotation, you'll lose 90 degrees of axial rotation if I fuse you C1-2. What we really can't say as well is what their actual consequence will be for their everyday life. Part of that is a lack of really quantitative ways to measure disability in a way that's meaningful for neck movement. The gold standard and primary, this has been done in the lumbar spine. Dr. Hart and his colleagues at Oregon developed a metric tool to assess the effects of loss of lumbar mobility on functional outcomes. They developed a 10-point scale, the Lumbar Stiffness Disability Index. This has been actually used, this is just a portion of the studies, to really provide valuable insights into the functional consequences or lack thereof in lumbar fusion. I can't go over this in this talk, but if you're more interested in this, you can check out his lectures on SSFTV. The Neck Disability Index, in contrast, is the principal index used for assessing disability in the cervical spine. It's a 10-point questionnaire, but unlike the lumbar stiffness disability index, it's focused primarily on pain. 3 of the questions are asked directly about the patient's subjective experience with head pain. Do you have pain right now? Do you have headaches? 6 of the other questions do address functional limitations, but again, primarily related to pain. Do you have pain while driving? Is it bad pain? There's also 1 question on sleep quality. Each item is scored from a 0 to 5, and this is another key limitation which will come up. The minimal detectable change is between 5 and 10. Why is this not a good index for assessing disability due to loss of neck motion? Several reasons. Like I alluded to, it's focused more on pain rather than loss of function. You could have a relatively high neck disability index without loss of neck function or loss of function. The minimal detectable change is 5 to 10. With a ceiling and floor, that has some very some consequences at the extremes of the index. If someone goes from a 5 to a 0, it's unclear whether this represents a significant change or not because there's a floor to how much can be measured, which combined with a relatively high MDC limits the applicability of both extremes of non-disability and disability within the index. Finally, there's significant temporal variations. The interclass coefficient, a measure of stability of the test over time, varies between 0.6 and 0.9 in the literature. If you talk to someone now and a month from now, their NDI could be very different, which is not sort of something you'd want in assessing disability to a stable condition like neck stiffness. In terms of development of the CSDI, this is really the consequence of work of Dr. Hart and Andrew Jack did last year. Using a modified Delphi process, they identified initial 24 domains based on literature, which could potentially be affected by neck stiffness, and over several rounds of expert panel refinement consisting of both attendings and fellows at Swedish, as well as both local and international experts. They refined it down to 10 total questions of 10 functional domains, which could be reasonably expected to be affected by loss of neck movement. Things like dressing yourself, looking up to attend an overhead item, participating in conversation, driving, etc. These are scored on a 0 to 4 point scale, ranging from able to do without any hindrance to unable to at all. Obviously, we have this metric, and it seems plausible. Obviously, with the Delphi process, experts agree that it seems like a valid metric, but that doesn't necessarily mean it's valid. And the real question of any good test, is it any good? The ideal test or ideal indice would consistently measure functional ability due specifically to loss of neck function in a consistent manner. Consistency is measured by a couple of parameters. Cronbach's alpha, this is a measure of how internally consistent the questions are. Do they address the same thing, or are they assessing multiple different aspects of the neck? And then correlation of test scores over time, the interclass coefficient. Perhaps more important, you care about the external validity. You want to be able to demonstrate that increasing disability correlates with loss of neck motion. This is done with a correlation statistics, Spearman's row. And then finally, you want to make sure it's better than existing metrics. You do this by comparing the correlation between neck stiffness and as assessed by the CSDI and disability as claimed by MDI to some surrogate of neck stiffness. In order to validate this, we propose a prospective administration of the test at 1-month intervals to patients who've undergone neck surgery of varying levels, ranging from arthroplasty and laminoplasty, all the way to complete occipital-cervicothoracic fusions. Our inclusion criteria meant they had to have radiographically proven fusion. We limit our ages to 18 to 80 to limit disability due to age. And we also excluded patients with either pan-spine fusion conditions or systemic conditions such as infection or cancer, which could cause disability. One of my co-fellows, Clifford Pierre, and not pictured here, Morgan Alexander, really pushed this process through IRB and were instrumental to this. In terms of validation, using this methodology, we identified 117 patients via screening. Of those, 23 were unable to be contacted or declined involvement. 28 had contact information, but just simply have not picked up their phones yet. And 48 patients have filled out the initial consent after agreeing to do so with a 76% response rate. In terms of actual test characteristics, the alpha, Chronobox alpha, is quite excellent, 0.95. Anything above 0.9 is considered excellent, demonstrating that the test is internally consistent, meaning the questions assess the same thing. Interclass coefficient is pending further responses. We still don't have the complete data to address that issue. In terms of external validity, obviously the ideal would be to show that neck stiffness correlates with the increasing CSDI score. Unfortunately, neck stiffness would require assessment via cervical gonometry in order to assess both rotation as well as flexion extension. In addition, we just didn't have the flexion extension films in follow-up to form an adequate sample to assess this. Therefore, we decided to use a number of levels fused as a surrogate for neck stiffness. There's some issues with this, but given the limitation study, it's sort of what we have. When we actually performed statistical comparison, as to demonstrate in this chart, depicting number of levels fused on the x-axis and increasing cervical stiffness disability on the y-axis, we demonstrate a moderate correlation between the two findings, as demonstrated by Spearman's row of 0.46. To give you a context, that says about 20% of the variance in the CSDI score is explained by number of levels fused as a surrogate for neck stiffness. 20% may not sound like a lot, but this is also the amount of variance explained by parental height, that a child's height is explained by parental height. As you can see, our surgeries included a broad swath surgery ranging from arthroplasty and laminoplasty, is red, and red, green, to posterior surgery such as posterior fusion and laminoplasty, although the bulk of our surgery did comprise posterior fusions. Like I said, our Spearman correlation was 0.46, which in the grand scheme of things is not as high as these sort of things can go, but it certainly was the highest in the data set. Correlating our neck disability index with a variety of other parameters, including age, BMI, cervical sagittal alignment, demonstrated that the correlation between the CSDI and number of levels fused represented one of the strongest in our data set. In fact, the only other parameters that seemed to significantly correlate were cervicothoracic fusion, a marker of long segment fusion, and then the NDI itself, which again makes sense. Disability in one domain most likely correlated with disability in the other, given that the NDI does have some assessment of functionality. So this begs, I think, the biggest question here is, do we really need another disability indice? If the CSDI correlates strongly with the NDI, and they do with a R value of 0.71, is the CSDI adding anything to the conversation? I'd argue the answer is yes on two fronts. The first is that as a marker for the effects of neck stiffness on disability, while both correlate with disability, the correlation is significantly strong between the CSDI and number of levels fused, as indicated by this correlogram, where a more linear, bluer correlation is indicative of a strong correlation than the correlation between NDI and number of levels fused, suggesting that this is a better measure of disability due to neck stiffness. The other reason is less numerical and more functional. Like I said, the NDI is primarily a measure of pain. It doesn't really give us a sense of what you lose functionally with a stiff neck. Although this data is still very preliminary, some interesting patterns have emerged from a closer, more granular analysis of the cervical stiffness disability index. One question we had is, what bothers patients most? When you do a neck fusion, what are they most likely to relate as the highest level of disability? Is disability distributed evenly, or are there clear domains that are affected more than others? Surprisingly, the domain that seemed to be most affected, the area that patients ranked as the most difficult, normalized the rest of the responses, is neck extension, looking up to get something off an overhead shelf. Other areas of domain, other areas of increased disability are areas affected related to neck rotation, such as driving or participating in a multi-directional conversation. This is especially striking since the number of upper cervical spine fusions, occipital cervical and atlantoaxial fusions, are relatively small. I think, 5, patients in the total cohort, suggesting that this is a problem even for patients undergoing C2 to T2 fusions or smaller subaxial fusions. Obviously, as we get more data, I think we can draw some more interesting conclusions from this, but I think this really shows the potential utility of this index as an alternative or a complementary index to the NDI. Limitations are a couple. I think one of the biggest is that assuming that number of levels fused correlates with neck stiffness. There's some reasons to think that this might not be the case. Patients subjectively will report after one level fusion that their neck is less stiff, a one level ACDF. In addition, the fusion is nonlinear with respect to number of levels. A C1-2 fusion is going to remove significantly more neck, make the neck more stiff than a one level ACDF. Other factors are related to the patients themselves. Disability, inability to perform something is partially related to patient factors like grit, level of neurologic dysfunction, and even posterior neck disruption that are independent of the so-called stiffness of the neck. Future study designs incorporating cervical goniometry and prospective baseline collection data prior fusion, I think, could adequately address this, but those are outside the scope of a pilot validation study. Conclusions. The CSDI measures functional outcomes due to neck status with excellent internal consistency and reasonable external validity. It provides a better metric, I think, for assessing disability in patients, especially with larger loss of neck motion due to its functional focus and superior correlation with neck stiffness surrogates. And finally, activities into neck extension and rotation appear to be particularly effective in patients who have undergone neck surgery. Are there any questions?
Great work. Thank you. Can you go back to the correlation slide that you had in the very beginning, I think the first Spearman correlation graph? This is a really important work, and just elucidating what actually affects patients is a big deal for us. Now, in this diagram on the left side, if you can highlight that, you have a couple of motion-preserving procedures, since we showed those earlier. Those green dots and those green dots are artificial discs, right? So they have no stiffness.
Yes.
On the far left, and then we have laminoplasty as light blue dots. If I look at this, there are some patients who have significant stiffness complaints despite having no fusion. So how do you explain that?
There are a couple possibilities. Again, especially with the arthroplasties, it's known over time that patients can undergo heterotopic ossification. I have not checked to see whether these patients have evidence of early heterotopic ossification. That's one possibility. The alternative explanation is that even though they are not fused per se, especially they undergo arthroplasty with a constrained device, they nevertheless may lose some lateral bending or rotational motion. Again, this is kind of hand waving and unlikely to be true, but again, this gets to a limitation of using number of levels fused as a surrogate for neck stiffness. Even laminoplasty, which is a non-fusion surgery, has been correlated with neck stiffness. I think it's in the Japanese literature, subjective complaints of neck stiffness.
And I think you've done that. One more question, then we have to close due to time constraints. Very interesting study. If you plotted upper cervical fusions versus lower cervical fusions, would your stiffness index show a difference?
You mean incorporating the two as a parameter?
Yeah, so if you just compare patients who had an occiput through C2 fusion, the patients who had fusions just below the C2 segment.
Yeah, I did try to address that statistically with a multivariate model, so incorporating atlantoaxial and occipital cervical as separate variables. I think this is an issue of numbers. If you look at the patients who get atlantoaxial fusions, usually they're trauma patients, and usually they're old. So, you lose a lot of patients follow-up. So they represent a relatively small portion of the studies. Like I said, I think we have 5 patients maybe.
Can you highlight that in your dot?
Nevertheless, there does appear to be a correlation between increasing CSDI and atlantoaxial. It's just hard to prove independence of number of levels fused. The same is true of occipital-cervical. I think the number of patients is too small to really register. It gets, within our current cohort.
So I hope you'll be able to present this at the Cervical Spine Research Society, who co-funded this study this winter when things open up again. Great work.
All right.
Thank you, and thank you all for watching.
All right, perfect.